I'll be presenting today. The topic of the conversation is understanding autism spectrum disorder in the context of immigration, insights from Manitoba-based research. But before I start, I want to acknowledge that I work and live on the traditional territory and homeland of the Treaty 1 First Nations and the Red River Métis. And as part of the community here at the University of Manitoba, we reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. So the objectives of today's presentation are basically three. We'll review the diagnosis, etiology, and prevalence of autism spectrum disorder. We'll talk about the research that we've been conducting here in Manitoba, trying to determine and understand if there's a link between autism and immigration, and then discuss potential mechanisms that may play a role in this association between autism and immigration. So before we start, I know that this is a community of developmental pediatricians, so I'll go fast perhaps during these first few slides. But, the diagnosis of autism is a clinical diagnosis, and for that, we use the DSM-5 criteria that came out in 2013. For a child, I guess I'm talking about children here, so for a child to meet criteria for a diagnosis of autism, they need to have all 3A criteria. All the 3A criteria talk about persistent deficits in social communication and social interaction, and these include deficits in social emotional reciprocity, deficits in nonverbal communicative behaviors used for social interaction, and then deficits in developing, maintaining, and understanding relationships. In addition to the symptoms A, children should have at least two of the symptoms B, and these represent restricted repetitive patterns of behavior, interest, or activities that include stereotype or repetitive motor movements, use of objects or speech, insistence on sameness, having difficulties with changes in routine, highly restricted, fixated interest, and hyper or hypo-reactivity to sensory input. But in addition to A and B, it's very important, and it's part of the criteria that symptoms must be present in the early developmental period, and these symptoms are actually cause a clinically significant impairment and are not better explained by intellectual disability or global developmental delay. Intellectual disability and autism, or global developmental delay and autism, can co-occur, but the most important part of that is that to make a comorbid diagnosis of autism and intellectual disability, social communication should be below what's expected for the general developmental level of that child. Then autism can or not have intellectual language impairment and can be associated or not with another neurodevelopmental behavioral disorder or a known medical or genetic condition. This is I just included for a bit of a description. When we give a diagnosis here in our clinic, we tend to include this pamphlet or infographic where we reviewed with families the criteria for a diagnosis of autism. Since 2013, when levels were first kind of reported and described by the DSM-5, we've been talking about severity of autism based on these three levels. Level 1 is a child that requires support, level 2 requiring substantial support, and level 3 requiring very substantial support. And as you can imagine, the severity determination is also impacted by cognitive, language, and behavioral functioning, and also including the adaptive abilities of the child. We're basically meaning that the level can be determined by different factors. So how do we diagnose autism? There are three approaches recognized by the Canadian Pediatric Society. The first approach is basically an experienced clinician who independently diagnoses autism based on clinical judgment and DSM-5 criteria and can or not include a diagnostic assessment tool like the ADOS. The second approach is a shared care model where a clinician has joint responsibility with another healthcare provider. It can be a speech and language pathologist, an OT, or it can be a psychologist and a physician, for example. And the third approach is a team-based approach where there's a diagnostic assessment team and it's done in a very kind of multi or interdisciplinary way. In Canada, the three approaches are accepted, and oftentimes what defines what assessment we're doing is the access to funding and which one is determined to be needed. So what do we know about etiology of autism? At the moment, there are recognized, three factors that play a role: genetic factors, epigenetic, which talk about how the environment and our behaviors can impact how our genes express, and also environmental factors. So the three are recognized to be playing a role in the etiology of autism. Just a little bit of, in terms of, where do we think autism may be coming from. A few years ago, one of our fellows did a study looking at comorbidities of children with autism that were diagnosed in our clinic. And we left kind of at the very end of the article, we came up with a question in terms of how we should be talking about autism, and is there a need to talk about primary autism, basically a diagnosis made in a completely healthy child, versus secondary autism, which is a diagnosis made in a child who meets criteria for autism, but also presents with a clear neurological or congenital conditions. Or for example, it could be a child that has had a stroke and also has CP and also has autism, or a child with tuberous sclerosis and autism. So perhaps thinking about this could help us in terms of understanding risk for autism, but also perhaps clarity for research. What do we know about rates of autism in Canada? So the data that we have at the moment in Canada is based on the 2019 Canadian Health Survey on Children and Youth, commonly referred as CHISI. And based on these numbers, 1 in 50 Canadian children up to the age of 17 years were diagnosed with autism. Rates may vary a bit between provinces, but basically we talk about 1 in 50 Canadian children having autism. Age of diagnosis is about 3.5, which I think in general people would agree. But very interestingly, although we don't have the new data, so there's a new version of the CHISI that should be releasing data very soon. What we are seeing from information coming from the States and other developed countries is that rates of autism have been increasing in the recent years. So this is a study that was recently published April 17th, 2025, coming from the States. And they talk about 1 in 31 children up to the age of 8 years having a diagnosis of autism. Numbers have been changing over the years. Used to be, 1 in 68, 1 in 59, later 1 in 54, and it seems like we are now 1 in 31. So this talks about the need to really understand, why is this increase happening, and I believe there's a need to identify groups that may have a higher probability of having autism. So how do we approach the diagnosis of autism in Manitoba? What happens in our province? So Manitoba has a very centralized approach for autism diagnosis. So the Rehabilitation Center for Children is located in Winnipeg. It's the largest, primary, and only publicly funded site for evaluation of children up to the age of 6 years who have developmental delays or who are found to be at risk for a diagnosis of autism. Children are assessed and diagnosed through the Child Development Clinic and the Neonatal Follow-up Program. It's a very centralized approach. Children have to be diagnosed in our center and some of the satellite clinics, but all the information travels back to the RCC located in Winnipeg. So, anecdotally, we had found that there was a high number of immigrant families coming for evaluation of autism at our center. We had one of our first meetings early during the COVID time where we're trying to understand, is this something that we're just seeing isolated way, each one of us in clinic, or is this just more something that we should be looking at? So we had a meeting, a few of the physicians and the other health professionals, and we discussed this and the need to start looking at this in more detail. We had not only noticed that we were seeing a significant proportion of children that were coming from immigrant families, but in general, children were not always born in Canada. Parents were born in Canada and also outside of Canada. Parents worked long hours, often shift work, and often children were not at daycare. So first step, we decided to do a literature review. One of our fellows at the time conducted, as part of her project, a lit review on the topic. And to our surprise, there was a significant amount of research that had found or had described a possible association between immigration and autism. Several articles coming from Europe, the States, and Australia described a higher representation of immigrant families among those diagnosed with autism. This is an article actually done as early as the early 70s, and the results had been published at this time in a newspaper in Australia. In Canada, we tried to look for information, and the only thing that we could find was a systematic review done by a group at McGill, and I'll talk about this article a little bit later. And then we started looking at the news. Have we found anything? And what we found, the first thing was a news article that came from CBC News 2007. It talked about a Montreal physician being concerned about autism rates being perhaps higher among immigrant families. And what these doctors said at the time is that he was, if you can see it here, will ask the Quebec government for help funding the research on the topic. But unknown to us, this research never really happened. And then we found another news article from 2009 where the Somali community in Toronto, again, they were also reporting significant rates of autism in their community, and they were looking for some answers. And the Somali community in Minnesota has been working with the government and developmental pediatricians because it's known in their community that they have high rates of autism. So despite those news articles, not much known about autism and immigration in Canada, despite the fact that we have a significant representation of immigrants in our country, immigrants making up the largest share of the population in over 150 years. And so we thought that this was an important topic to review. So that's how we decided to embark on our first study. We got a relatively small grant from ENRRICH, which is our neurodevelopmental group here in Manitoba. And we decided to look at this possible association, but in our center. So what we did, we looked at the electronic medical records of all children that were diagnosed with autism in our center between 2016 and 2021. Our cases were defined, so we were interested in any child born in or outside of Canada who had at least one parent who was an immigrant. And we compare, how many children had immigrant parents to the proportion of Manitoba's population who were foreign born based on 2016 and 2021 census data. So what we found is that 36% of our patients here at Sky had at least one immigrant parent, and this was higher than the proportion of immigrants living in Manitoba, both in 2016 and 2021. And immigrants came primarily from Asia and Africa, which is, the areas of the world where most immigrants are coming from in Manitoba. When we compare those without parental immigration to those with parental immigration, what we found in general is that a higher proportion of those coming from non-immigrant families had family history of autism. Interestingly, we wanted to know if prematurity was playing any role, and actually there was no difference. So it's the same rates of prematurity in both groups. We also were interested in understanding, did we use ADOS in the same amount of children in both groups? And there was no statistical difference, meaning that ADOS was used similarly in both groups. And then we looked at associated neurological comorbidity, and we found that in general, those coming from the non-parental immigration had higher rates of associated neurological comorbidity. So this was a relatively simple study. What we found were children with autism and immigrant parents had lower rates of family history of autism and lower rates of neurological comorbidities than children with autism but without immigrant parents. And we thought that these findings may then provide clues regarding the possible role of the environment in this association. So this was published last year at the CPA's journal, and we thought it was relevant because it's the first Canadian study to examine a potential link between autism and immigration. But we did recognize it was purely a descriptive study with several limitations, and it led us to think that we needed to do future research. And that's how we moved to our second project, where we decided to look at this from a population level perspective. And for that, we received some funding support. So again, similarly, we were looking to compare the incidence of autism among those coming from an immigrant versus non-immigrant families during May 2016 to 2022. And for that, what we did is we linked our autism database to the Manitoba Population Data Repository, which contains health, education, social demographic information, including immigration, from all Manitoba residents. And to get the information from immigration, the Manitoba Population Data Repository links to the Immigration, Refugees, and Citizenship Canada Permanent Resident Database, which has a linkage rate of over 96. So we included all children 18 months to 6 years of age that were born or had come to Manitoba and were living in the province during the study period, but we excluded those with missing or invalid healthcare numbers because we then couldn't link them and couldn't get the information on immigration that we needed. We also excluded those with extreme maternal ages, international adoptees, and immigrant children who arrived in Canada after their third birthday. And there are two reasons for that. The first one being that due to delays in assessing children, a child might have come, let's say, at 3.5, and until they see a pediatrician and then they get a referral to us, then we may be missing some true cases. And also importantly, we wanted to make sure we were not including cases where the family moved to Canada to perhaps considering trying to get further services. So then we divided our patients in three groups: Canadian-born children of non-immigrant parents, being Canadian children of Canadian parents. The second group was Canadian-born children, so children born in Canada from immigrant parents. So either one or both of the parents had come to Canada. And the third group was immigrant children of immigrant parents. We calculated incidence rates. We then calculated also relative risk. We did account for clustering of children within parents, meaning more than one child may be related to the same parent. And then we did secondary analysis exploring the contribution of both parents. So we're trying to understand, is the risk associated to mother only, father only, or dual parent immigration? So we included a significant number of children, out of which a total of 2,412 children were diagnosed with autism. Of those children, about 3/4 were male, a little bit less than half were firstborn, about 10% were born prematurely. The significant majority actually didn't have any significant medical comorbidities, and about 1/4 of them lived rurally. Of the 2,412 children with autism, 1,137 children, which is 47.2% of all children, were coming from immigrant families. 41, so almost 42%, were Canadian-born children of immigrant parents, and 5.4% were immigrant children coming before the age of 3 with immigrant parents. These told us that children of immigrant families comprised 29% of the total study sample, but 47% of all autism diagnoses. When we looked at the cumulative incidence, which is here in this green box, cumulative autism incidence per 1,000 children was 8.2 in Canadian-born children of non-immigrant parents, 18.6 among Canadian-born children of immigrant parents, and 14.2 immigrant children of immigrant parents. When we calculated relative risk, it was 2.3 for Canadian-born children of immigrant parents when we compare them to Canadian children of Canadian parents, and 1.7 when we were looking at immigrant children of immigrant parents. This is a bit of a complex figure, but what we did here is we compare children of immigrant parents to Canadian-born children of non-immigrant parents, and what we found is basically all subgroups were at higher risk for autism except those born in Europe. And this is the comparison between among immigrants, and what we found is that maternal length of stay was not significant after adjusting for significant variables. And then those at highest risk were those coming from Asia and Africa. Refugee status, as you can see here, was not statistically significant when we compare among groups, but having been born in Canada was significant. This is looking at, what I referred, that secondary analysis that I referred earlier, who are the ones who appear to be a significant risk when we compare, is it the mom, the dad, or both parents? And the highest adjusted relative risk was for those with both immigrant parents. And when we compare the three groups among themselves, again, the highest risk was for those with both immigrant parents, and having a mom or a dad, when we compare among themselves, was not statistically different. So this was the first population study in Canada to examine incidence of autism according to immigration status. Children of immigrant families in Manitoba had higher rates of autism diagnosis, particularly those born in Canada to immigrant parents and those with dual parent immigration. We did not find association between length of mother's stay in Canada and the risk of autism. And similarly, we did not find that refugee status increased risk beyond the broader impact of immigration. So now moving into the third objective, which is discussing mechanisms that may be involved in this association. So before I jump into this area, I have to acknowledge that I'll be talking about some studies that were published a long time ago. And the reason for that is that there's been quite a bit published on this topic, but only the older studies seem to have been looking specifically at what factors of their lives could place them at risk, and some use language that is outdated. So I will just say this in advance. So this is a study from Australia. A psychiatrist and a psychologist found increased rates of autism among immigrants, particularly people coming from Greece and Germany. So they decided to really look at how they were living. They studied their daily life and trying to understand what may be placing them at risk. So I am quoting exactly what came of that article, because I can see, for example, they used the word wives and not mothers. So 70% of Greek wives work compared to 30% of Australian wives, and children are left to their own devices. Parents work long, hard hours and are too tired and irritable at the end of their day or shift to cope with their children's problems. It is not uncommon to find that small children are left by themselves while their parents serve customers or while the father is at work and the mother is sleeping before going on a night shift. It was the first time ever that I found in a study talking about shift work, because we had found that clinically, but actually this was talking about perhaps the role of shift work. Then the authors say that under these circumstances, the notion of sensory deprivation and environmental stress as a common variable in the histories of autistic children is of considerable importance. The author suggested that the stresses of cultural change and the socioeconomic pressures borne by their parents resulted in deprivation of their children who were also exposed to a confused language environment, and that a combination of these variables could lead to a decompensation into an autistic state in an already vulnerable child at a critical period of development. So I just want to mention a few things about this statement. First, what they refer to as a confused language environment, because research has shown that families, children of families that speak two languages are not at increased risk for autism, and that is well known. But the authors talk about here, they describe parents speaking to their children a language that is not their own. So, for example, I'm from Argentina, I speak Spanish with my children, but instead of doing that, I will be forcing myself to speak English with my children. And often these parents were not very proficient in English, but they were forcing themselves to do so. And they were thinking about that as a confused language environment. And then the other thing that I want to talk about is this was published in the early 70s, and they talk about a critical period of development, those initial years of life. And this was research done later by a group in California, also mentioned quite a bit by a group in Harvard, about the importance of the environment during the first years of life, which they call also a critical period of development. So what the authors were saying is what's happening in these children's environment during these critical periods of development. Can the stress of the parents adjusting to a new life be affecting this environment? So I think it's not a surprise that immigrant families, may be struggling, especially when they first come. These studies coming from Europe. This is a Portuguese group. They talk about almost all immigrant families, but especially first-generation ones suffering from the absence of closed kin networks and support to support their childcare. They have a strong pressure to work and from work, long or typical hours, and they may have difficulties with integration, including social isolation, lack of information on services, and problems with housing. This is a study coming from Montreal. It's relatively a newer study. And this study actually highlighted the social isolation and loneliness faced by immigrant mothers, mainly due to the loss of family and cultural networks. But what's interesting about this study is that they talk about the impact of the isolation, not only on the mom's emotional well-being, but also how these isolation limited their child's social opportunities, particularly children who were not enrolled in childcare. So other studies, this coming from the UK, I won't mention all the studies that have been published in the area, this just as an example. These authors from the UK did not actually explore reasons for increased risk for autism like the Australian group did, but they did talk about interesting parallels with schizophrenia and psychosis, because it's well known and well recognized that immigration is one of the biggest risk factors for schizophrenia. And psychosis is reported to be present in all immigrants, irrespective of ethnicity. And in general, when you look at that literature, environmental factors are recognized as a significant risk factor. They also mentioned that in the area of schizophrenia, selective migration, obstetric complications, vitamin D deficiency, and infections have been also studied. Similarly, in Sweden, this group trying to understand why they were seeing higher rates of autism. They talk about maternal stress, and they talk about the need for future research. Very recently, a group from the Netherlands did another large cohort study, and they found that stress, both in pregnancy and after pregnancy, may be playing a role in this association. But interestingly, this group from Sweden talked about, well, it seems like maternal vitamin D deficiency, nutrition, and early life infections should be looked at. However, these have been really studied in the area of schizophrenia, and despite years of research, the mechanism of these possible factors remains unclear, meaning that perhaps we could think that here they also remain unclear. Another study also coming from Europe, again, talking about a higher representation. I won't go into too much detail. Now, in terms of, understanding how different it may be, raising a child in a new country for immigrant families, these researchers from Cambridge have been looking at how, different communities in Africa, and of course, these may be an extreme of an example, but how they raise their children, and they compare how these communities may be raising their children to the way we raise our children in more developed countries. And what they found is that these communities have a lot of what's called alloparenting. So a child is being cared by multiple people in their community, and the people taking care of children may be, kind of older children, young adults, and the parents or friends in the community. And this is very different to the way we raise our children, where usually there's a parent per child or two parents per child. I apologize. This is another interesting study. I'm sorry, it's not a study. It's an interesting news article that somebody, because they know I've been working on this area, shared it with me. But this is a journalist from Uganda that describes in this article that was published in The Guardian the difficulties that she had when she had to move to Switzerland for work, and how that really impacted her as a parent. And if you ever have, some time to read this article, please do, because it really gives us a perspective in terms of the challenges that some of the families that we serve may be going through. And now going back to the study that came from the McGill group here in Canada, they did a systematic review. And what they found, the systematic review was actually on maternal migration, not parental. It was maternal migration. And what they found is that nurturing social cultural conditions may protect the reproductive environment and reduce chances of having a child with autism after maternal migration. They proposed that maternity migration stressors and poor environments may cause epigenetic changes during pregnancy that lead to autism. That's their hypothesis. But the authors really think that there should be wider knowledge dissemination about this research, and there should be more community engagement, because they feel that could really spread the message of the potential benefits of a nurturing community. And they really call for a joint collaboration between life scientists, social scientists, and medical humanists to understand this better. And they talk about the need for interdisciplinary research that could consider investigating autism from a diverse biological, social, and cultural perspective. So in summary, there's a large body of literature showing an overrepresentation of autism among children of immigrant parents. Is this multifactorial? It seems like it is, but stress is recognized as a factor that should be further studied. And there's, and I'm quoting Dr. Krafa from that systematic review, it seems that there's a need to investigate autism from a diverse biological, social, and cultural perspective. So where do we go from here? Well, we were able to present these at an oral presentation at the International Society for Autism and Research meeting in April. we moved a step forward, and we had a medical student working with us this summer. And the purpose of that project was a very simple project where we interviewed 10 allied health professionals and 5 parents, because the question was, this is what research has found. We want to move the research forward. What are things that we should be looking at? And they agree that we should be looking at challenges that happen at the home environment, stressors related to isolation and perhaps the trauma of immigration. Also, we should be looking at the process of acculturation, and many of them talked about the difficulties that they have in accessing programming and information, which we think that this, without them really knowing about this, it agrees with, a significant amount of research that has been looking at these things. We also had a chance to have discussions with Dr. Charles Nelson from Harvard, who kindly invited us to present for them. That's happening in November. He did research looking at autism among a group of Romanian orphans, and he talks about the role of psychosocial deprivation as a risk factor for autism. Not saying that it explains every case, but in some cases it could increase risk. For those who are interested, he has a very interesting study that he published in 2018 about how psychosocial deprivation can shape early development and its impact on these children's lives. In terms of advocacy, we met with the Manitoba Minister of Labor and Immigration, and that was actually a very interesting meeting. She wanted to know, we said we only have data showing that we have an overrepresentation. We don't know why exactly. And she was quite interested in knowing what to do to help the immigrant families. And we said, well, we'll have more data for you in the future. But in the meantime, I said, when we had our meeting, we think we should be trying to impact the environment. And she said, well, many of the things that you're mentioning are done by the HIPPY program here in Canada. For those who don't know it, I didn't know it before I met with our Minister of Immigration. HIPPY stands for Home Instruction for Parents and Preschool Youngsters. It's a program that actually runs across Canada, but it's done by Mothers Matter Canada, that is actually based in Vancouver. And then here we had the chance to present for the Manitoba Association of Newcomers. But I did want to quickly talk about Mothers Matter Canada, this organization that runs the HIPPY program. We met with Yusra, who is, I think, one of the representatives. And she talked about the program, how it's run, where it's located in each province. It seems to me, based on the information that we have from our province, that in our province, at least, the rural programs seem to be working a bit better. But these are mothers visiting families at home with a developmental program to encourage development. And then really, we don't have any research explaining why this may be happening. We only, as I said before, have research showing that there's an overrepresentation. But I think we talked about the role of the environment, and perhaps in the meantime, there's something that could be doing at the environmental level. And when putting my clinical hat on, when we talk to these families and we ask about, particularly those that parents are working long hours or shift work and kids are not at daycare, I ask about social play and opportunities for social play. And when they talk to us, they really describe limited opportunities for that. So we discuss the need for social play, for an enriched social environment. If they cannot really pay for a daycare, we talk about the need for peer exposure, so library groups, daycare, meeting colleagues and friends that have children their own age. We often give them information about community activities and library groups. We really talk about the importance of parents speaking their own language. And again, this is coming from a clinical perspective, but I often tell families, well, if you speak, for example, the Spanish example, or Tagalog, if you speak Tagalog with your partner and with your mom who's still in the Philippines, but you speak English to your child, think about the percentage of, or the amount of conversations that your child is missing. So really important to encourage these families to speak their own language to their children. We also need to talk about screen time and the need to be spending more time outdoors. And also, very importantly, it is tricky. I know sometimes because when we want to ask about mental health, we want to be prepared with resources, and sometimes we don't have those resources. But I think we should be working more on this. Some resources that we share with families, library groups here in Winnipeg, for example, but there are a lot of resources out there to talk about screen time with families, but also about the importance of outdoor play, and also very importantly, how to dress for the weather, because at least in Manitoba, if you're not wearing the right clothes in the middle of winter, you're not going to be able to spend much time playing outdoors. And I think that takes us to the end of our presentation. How did I do?